patient suddenly develops shortness of breath, tachycardia, and hypoxia. Miss this diagnosis, and the consequences can be fatal. This is pulmonary embolism, a potentially fatal cardiopulmonary emergency where sudden hypoxia and right heart strain can rapidly destabilize the patient. The first priority is immediate stabilization. Start in the emergency department and move the patient to the intensive care unit if unstable or worsening. Begin stabilization with oxygen, pulse oximetry, intravenous access, continuous cardiac monitoring, and frequent vital signs. With stabilization underway, perform a focused cardiopulmonary exam along with an extremity exam, looking specifically for unilateral leg swelling suggesting deep vein thrombosis. Watch closely for tachycardia, hypoxia, pleuritic chest pain, and signs of right heart strain. As the evaluation continues, begin the diagnostic workup. In any shortness of breath or chest pain patient, immediately obtain electrocardiogram and chest X-ray. Send core labs including complete blood count, comprehensive metabolic panel, coagulation studies, troponin, and arterial blood gas. The key confirmatory test is CT pulmonary angiography with contrast. If contrast cannot be used, obtain ventilation perfusion, VQ scan instead. Also order Doppler ultrasound of the lower extremities to identify deep vein thrombosis as the embolic source. For risk stratification, brain natriuretic peptide, BNP, and echocardiogram can help evaluate right ventricular strain. D-dimer is only useful in low or intermediate probability cases. Do not order it in obvious high probability pulmonary embolism. Once the diagnosis is established, treatment should begin immediately. In hemodynamically stable patients, start anticoagulation immediately with apixaban, rivaroxaban, low molecular weight heparin, or heparin infusion bridged to warfarin. In massive or unstable pulmonary embolism with hypotension or shock, transfer to intensive care and give thrombolysis with alteplase. Catheter-directed therapy or embolectomy may also be needed. As treatment progresses, continue to reassess the patient's clinical status and level of risk. Stable patients may eventually discharge on anticoagulation with close follow-up. Patients with right ventricular strain, worsening hypoxia, or hemodynamic instability require intensive care monitoring. Throughout this process, remember the critical CCS traps. Do not forget electrocardiogram, troponin, or lower extremity Doppler ultrasound. Never order D-dimer in obvious pulmonary embolism. Do not delay anticoagulation once pulmonary embolism is confirmed, and always have a long-term anticoagulation plan before discharge. If you remember one thing, remember this. Sudden shortness of breath, tachycardia, and unilateral leg swelling mean pulmonary embolism until proven otherwise. Confirm the diagnosis with CTA, identify the source with lower extremity Doppler ultrasound, and start anticoagulation without delay. Thanks for listening. If this review helped simplify a difficult topic, consider subscribing for more high-yield medical education content, and let me know in the comments what topic you'd like covered next. Until next time, keep learning, keep growing, and keep expanding your horizons.